All right, everyone, we are going to move forward with the last session in this wonderful day that we've had, and I want to thank everybody for being here in person and virtually until the very end. As you can see, this is not the busiest panel or the largest panel that you've seen today, but I think it's going to grow over time. You know, the topic for this session is tech advancements in patient care, and there is a lot of work being done in this sense, and so I think moving forward we'll have busier panels, but I am joined by Dr. Ashwin Mallipatna, who is the head of the retinoblastoma program at the Hospital of Sick Children in Toronto, Canada, who will give the highly anticipated presentation about the test that you guys have taken earlier with the models there. I'm going to kick off the session, though. I'm going to start with my presentation. So I'm going to reintroduce myself. My name is Maura di Nicola. I work at Bascom Eye Institute in Miami. I'm an ocular oncologist. As Marissa mentioned yesterday, I've recently joined this amazing group of incredibly talented individuals in the We See Hope community, and I couldn't be more grateful and more honored to be part of it. So thank you so much. And I want to discuss with you a little bit of work that we've done looking at the role of artificial intelligence in patient information. These are my financial disclosures, which are not relevant in any way to the work that I'm going to present. And so artificial intelligence is a hot topic, right? Everybody, we've all heard about this. We've all heard about the launch of ChatGPT and other chat bots in this space. And so it definitely is a hot topic in our everyday life. You know, we've heard a number of stories related to AI, some very good and exciting, some a little bit concerning, maybe in a way. And ophthalmology is no exception to this. It's definitely, AI is very much a hot topic in ophthalmology as well. And there's a picture here on my slide that shows the number of publications over the years that you can retrieve on PubMed, which is our online database for biomedical literature, when you type artificial intelligence and ophthalmology. So there has been a lot of work being done in this space. And it's covered many applications, you know, from screening and imaging interpretation. We've heard a lot today about how certain areas are harder to reach for medical providers, or it's harder for patients to reach their own medical providers. And so there's a lot of work being done in potentially just taking pictures of the back of the eye and having artificial intelligence interpret those pictures to tell you if there's something wrong with the eye or not. And this is not just in oncology. In ocular oncology is in other diseases of the retina. For instance, diabetes. You know, diabetes can affect your eye. So there's a lot of work being done in this space. Other applications have included telemedicine. We've all become more familiar with this concept, whether we like it or not, because of the pandemic, all the way to teaching and education, so leveraging artificial intelligence to kind of educate the next generation of ophthalmologists. And so a little bit of basic terminology here. When we talk about what is a large language model? So a large language model is a subtype of artificial intelligence that is trained on vast amount of text data, hence the word large in its definition, and it's trained to not understand and generate human-like language. And there are a lot of large language models that are commercially available, such as ChatGPT, Copilot, Gemini, others that you might have heard of. And again, ophthalmology is no exception. Lots of work has been done looking at the application of LLMs, of large language models, in ophthalmology in many subspecialties. I have reported here on my slide a little bit of work being done in the glaucoma space, in the retina space, even again in the education space, seeing how these LLMs perform in answering questions that our residents and fellows are asked when they take their boards. But there is limited information on ocular oncology in general and retinoblastoma specifically. And so one thing that I'm sure we've all done, we're all familiar with this concept in this room, is, you know, when we are wondering about something that we don't know and we want an immediate answer, we're going to go to our phones, we're going to go to the internet, we're going to consult for anything. And the ophthalmology, ocular oncology, retinoblastoma space, I think, is no exception to this. And I have to admit to you guys that one of the hardest part of my job is when I diagnose a child with retinoblastoma, and I leave the operating room and I have to go to the room and consult with the parents, with the family of that child, because I know this is going to be a traumatic moment for them, and I'm going to unload a lot of information on that family about what their diagnosis means, what are the next steps, what the future holds for their child, for them. It's a lot of information to process. And we all process information and traumatic experiences differently. Some people are very present and are able to retain all of the information. Some people are overwhelmed. And a lot of it, the information that I transfer or try to transfer to the families in that moment leaves their brain almost immediately because it's too much to process. Sometimes you have family members back home that are going to ask you, so what did the doctor say? It's difficult to report all of that information to your family members at home. And so one thing that some people might do is go to this LLM, to these chatbots that talk to you in a human-like way to tell you more, to fill in those gaps that you might have. And this, I have a picture here that is a screenshot of an article that was actually published just last month in the New York Times that is called "The Chatbot Will See You Now," or "Dr. Chatbot Will See You Now." And so in this article, they showed that 1 in 6 adults and even a quarter of adults under 30 years of age resorts to chatbots and LLM at least once a month for medical advice, for medical information. So what we wanted to do was to investigate the utility of LLMs in addressing potential queries from patients affected by ocular malignancies. And we've done this with the 2 most common conditions that we encounter as ocular oncologists. In the adult population is uveal melanoma, so we've done that. I'm not going to present this data here because it's not really relevant to this audience. And then for childhood retinoblastoma. And so we compiled a set of common questions that are related to retinoblastoma, and we did this by looking at a number of sources. We did Google searches, we looked at websites of reputable medical institutions, and we looked at what questions were being asked in some publicly available patient advocacy groups. So we had a list of questions, and the final review of what were deemed the most relevant questions was determined by 2 ocular oncologists. And we generated the responses with 3 different LLMs. So we looked at ChatGPT-4, Copilot, which is the AI that Microsoft has, and Gemini, which is through Google. Just a little, I just want to highlight a little something here. We use ChatGPT-4, which is not freely publicly available. You have to pay a fee to access it, and there are some exceptions to it, but for simplicity, we'll say you have to pay a fee for it. The reason why we did this is it seemed other studies had shown that ChatGPT-4 is able to provide more accurate and more up-to-date information than ChatGPT 3.5, which is what is publicly available. But we wanted to go with explore what the potentially best option is out there. That's why we picked 4. And the questions encompassed many aspects of the disease, from the causes, the diagnosis, the treatment options, and the prognosis. And I don't want to necessarily read through all of the questions, but just to give you an idea of what we asked basic things. What is retinoblastoma? What causes it? What are the risk factors? Does it run in families? Do I have to have my children tested for it as well if one of my child has it? And then moving on to the staging. How does it affect vision? What are the treatment options and what are the side effects of those treatment options? What is the recovery process after treatment of retinoblastoma? What are the chances that my child with retinoblastoma loses an eye, and then what does that eye removal look like specifically, and what is the recovery after that? All the way to prognosis, so moving forward, looking at the future, what is the survival rate for retinoblastoma? What if it spreads outside the eye, and how often does that happen, and where is it going to spread? What are the chances that it comes back? How often and how long does my child need to be followed? And when is my child going to be considered cancer-free? So those are the 17 questions that we asked all of the 3 chatbots. And we had 7 ocular oncologists grade this answer. answers. And we use Likert scales, which I'm sure you're familiar with, because whenever you get a survey, that's pretty much what they use. It's a scale that goes from 1 to 5. We use 1 to 5 specifically to ask our graders about accuracy of the responses, relevance, and comprehensiveness. So 1 being the lowest score, so not very accurate at all, not very relevant or comprehensive at all. 5 being very, very good, performing as we would want it to perform. And then when the graders graded accuracy for a certain response 4 or less, we asked them to determine how harmful they thought those inaccuracies might be, and we use a scale from 1 to 3, 1 meaning minor inaccuracies that are not harmful, 2 meaning inaccuracies that could be potentially vision-threatening or cause harm to vision, and 3 severe inaccuracies that could be potentially even life-threatening. And then the other thing we did, we wanted to determine how readable, how accessible, how easy to understand these answers are. And those are just the 2 scales that they're just readability scales. So they give you a number to tell you how easy that text is, how readable it is based on the grade level. And that's what they're called. So for accuracy, at the bottom I have reported the mean scores for the 3 chatbots for all the answers. So you can see ChatGPT had a score of 4.5, Copilot around 4, and Gemini 4.3. So decent scores, and ChatGPT demonstrated higher accuracy than Copilot and Gemini, so performed better statistically than the other 2. And as I just mentioned, we asked how harmful they are, and the scores here, remember the scale here is 1 to 3, was 1.2, 1.3, and 1.2 for ChatGPT, Copilot, and Gemini, respectively. These are some of examples of the potentially harmful, inaccurate information that we found. So some LLMs confidently linked certain foods or environmental exposures to retinoblastoma to the extent that they, even mentioned some foods that could prevent retinoblastoma. And while there are some studies that have looked at environmental risk factors and that sort of thing, we don't have clear-cut answers when it comes to that. So that could be potentially harmful for patients to think that that's, the ground truth. There was no distinction, or, it became confusing when it comes to stage and grouping. Sometimes the wrong TNM classification was given. And then one thing that I found particularly concerning was that there was a mention of hematopoietic stem cell transplant as a primary treatment for retinoblastoma, and we've just heard that it's used but in a completely different kind of setting and not for primary treatment of intraocular, meaning retinoblastoma confined to the eye alone. These are the numbers for relevance, so how relevant are these answers? And again, 4.5 for ChatGPT, 3.8 for Copilot, 4.4 for Gemini. ChatGPT and Gemini here performing better than Copilot, still decent scores, so pretty good scores. You can see the scores drop when it comes to comprehensiveness. So the graders felt that the answers were not giving all of the information that we as physicians would want to give patients. So you can see for ChatGPT is 4, for Copilot is 2.9, and for Gemini it's at 3.9. And again, ChatGPT and Gemini seem to perform better than Copilot. And again, we asked, what do you think is missing in these answers that you don't think are as comprehensive as they should be? There was a lot of confusion when it came to discussing heritable and unheritable form of the disease. And based on the amazing genetics panel that we had yesterday, what we heard, I'm not surprised, because there are so many nuances. We talked about penetrance, we talked about mosaicism, all of these nuances, and we even talked about how sometimes we do have a geneticist in our center, but that geneticist is not knowledgeable when it comes to RB specifically. And it made me think, after I listened to the panel yesterday and I was looking at our work, where I thought, it might be hard for patients to reach the resource that they need, a geneticist that's knowledgeable in retinoblastoma. Even more concerning, that's where they might when they might resort to the LLMs, because maybe they're not finding the answers that they need in their center, so maybe they're asking a chatbot to see if that might help. So these are things that we need to keep in mind when we're kind of hopefully leveraging this technology for the future. There was limited information on staging, as I mentioned, limited information on treatment side effects, and potentially what to expect after examination under anesthesia, laser, and cryotherapy, or other things that were mentioned by our graders. Finally, for the readability, These are just the scores, the numbers. That's not important. What matters, the take-home point of this slide is, keep in mind that the American Medical Association and National Institute of Health recommend a 6th grade reading level for patient healthcare material so that it's accessible to people. The numbers that you see reported here, they correspond to a college graduate level. So these answers were a very advanced kind of reading level. They might not be accessible to everybody to understand, to read. We just talked about this earlier as well as being a challenge. So in conclusion, we thought that the performance of LLMs in terms of accuracy or relevance was pretty good. A little bit less when it came to comprehensiveness. There was definitely a risk of harmful inaccuracies, although not many, and a high level of education was required for readability. So what are the future kind of implications of this, and what are we looking at for future directions? So, I think a lot of people say, AI is coming. I don't think that AI is coming. AI is here. It's already here. So it doesn't make sense to try to fight AI. That's not what we should be doing, but we should be understanding how to use it to our advantage, to leverage it for something that we want to do. And so I think what we're trying to do at University of Miami, where I work, is we're going to try to create a tool that's monitored by physicians, so vetted by physicians, so that we can kind of train the models that have already been developed by these people that have a lot more financial stake on this than we can have, but leverage that technology to teach these LLMs to give accurate information to patients, so that as a physician, I can know that if you're looking up information, you're looking something that it's reputable. And you as a patient, if I cannot call you right back to answer your question, and that question is just like burning in your head and is causing anxiety, you have a resource to go to that is going to give you information that's accurate. And the other thing is that we can, again, leverage AI to improve the readability of this material and make it more accessible. You can train models to produce data that's at a different level, that can be interpreted by the 6th grade kind of level. And the other thing is language. Make this available in multiple languages. I work in Miami. 70% of my day is in Spanish. We have a Creole population. We have Haitian patients. To be able to reach patients in their own native language makes all the difference in the world. And so that's where we're looking at in the future. I would like to thank my co-graders. So these are the people that helped out in grading all of the answers and carrying out this work. And I want to thank my students and fellows that did a lot of the heavy lifting when it comes to this work. And just allow me to thank one more time the amazing group of people I've been working with: Marissa, Jess, Sandra, Lori, Clay. You're amazing. I couldn't be happier to be here and more honored. So thank you so much for having me. We're going to move on to our next speaker. So I'm going to pass it on to Dr. Ashwin Mallipatna, who is going to discuss 3D eye models of eyes with retinoblastoma for early detection and awareness.
First off, that was an excellent talk, Maura. Thank you very much for that. And I have a million questions. I hope we have time for that after this. I'll be quick with mine. Thank you to everybody over here in the room. I think I wanted to say that, you guys inspire these ideas, and I'm just here to present one of those that have been inspired by all of you. So my project is about 3D eye models with retinoblastoma and what we did with it and what I feel the impact is on early detection and awareness. This is a story that comes back from India about white reflexes. All of you, of course, know the importance of white reflexes. I don't have to tell you because you're here because of that mostly. But this is the power of the knowledge of a white reflex. So this is a photograph of a child at the child's naming ceremony. This is in a village that's about a population of 5,000 people in rural South India, far out beyond anywhere else. This photograph was taken by the village photographer. The village photographer took this photograph and went up to the parents of the child and told the parents of the child, look, there's this thing in the right eye, and this thing in the right eye might mean that your child has cancer. Now, this is a village photographer who has no education further than maybe high school education. How did this village photographer know this information? He only knew this information because he had a niece that passed away from retinoblastoma. So in effect, the knowledge of white reflex has been passed on because a child died from retinoblastoma. That is too expensive a lesson. We can't allow that to happen. There should be a better way for this to happen. So the challenges here are many. Healthcare workers have inadequate training in some places. There are competing priorities for the healthcare workers. They're asked to do a million things, and red reflexes may be one of them. There's insufficient exposure to things like retinoblastoma, which is, in all honesty, quite a rare disease in their parlance. My father's been a pediatrician since 1965 or so, and he passed away in 1995. And he told me that he's never first-hand diagnosed a child with retinoblastoma. And he's been a pediatrician who was, trained in Akron in Ohio, returned back to India in 1970 and practiced there till he passed away. So this is, even through his practice with the thousands and thousands and thousands of children he's seen, he still hadn't been exposed to retinoblastoma in the same way. With the patients and families, of course, there's also that challenge that we have to meet, which is access to medical care, which is challenging, as Guillermo and others pointed out today. That's just the basic facility that's required. Symptom awareness and cultural beliefs come in the way as well, either positively or negatively. And and being empowered to advocate for yourself, in other words, what Know the Glow does. They actually give the information to patients or to parents who can actually advocate for themselves now. These are the challenges that we face. What are the solutions to these challenges? In 2002, Tuca came out with a Brazilian TV ad that made a huge impact, and I don't know if everybody in the room has seen this, but that TV ad presented white reflexes and almost demanded that the parents show their child to a doctor when they see that white reflex. That ad was supremely powerful, and so was the Honduras poster campaign, which was actually measured to be of some importance. Then I think 2006, if I'm not mistaken, is the origins of Know the Glow, I would think. But it obviously became much more known after that, but it might have started at 2006. And 2009 was the PhotoRed project. I had coined the word PhotoRed when I actually looked at different digital cameras to see which ones can, in a repeatable way, elicit red reflexes. And that's something that's there in VC Hope's website as well, and all of those instructions are there as well. And 2013 to 2019 is when the Cradle White Eye Detection app started to come about. And really 2015 is the beginning of the ArcLight project, from what I can tell from publications. The concept might have been a lot older than that, but this is when we started to get to know about these things. How much of an impact have these made? Now, I think these have only made an impact to the extent at which people can still be aware of the disease. To go further than that, I think you truly need a phantom of the disease. In other words, you need something that can model and mimic retinoblastoma better than what exists. There are posters. Posters are two-dimensional. Not everybody relates with what they've seen in those posters. I mean, many people have learned from photographs and posters, of course, but that doesn't extend to as many as we would have liked to. And how much of those do represent what's real? That's a question that we have to ask everyone else. So we decided to then 3D print these eyeballs in color to accurately mimic the red reflex of retinoblastoma and other conditions. In fact, the white reflex of retinoblastoma and abnormalities of the red reflex that occur in other conditions. What we tried and tested with these 3D models that you've all seen on the table there, and that I can show you right here. We tried and tested these models for their optical properties. In other words, we actually tried to measure their refraction, and we would design these to be of a certain refractive error. You can also design these to be of a refractive error that's different. And so the fact that you can measure these things actually tell you that these are optically accurate. And these are pretty physiological. In other words, we've made them model racial variations in these colors of red reflexes and tried to mimic the color of retinoblastoma as much as we could, and not using only white, but also using a yellowish white to it. And we've also mimicked other diseases as well, such as this child. And I must reveal the answer to the question that we posed earlier today, is which one of these have retinoblastoma and which one of these have a cataract. The answer is this has a cataract and this has a retinoblastoma. Most people who saw it felt that this had a retinoblastoma in one eye, but the secret is actually that this model has retinoblastomas in both the eyes. One is smaller and one is larger. One is more peripheral and the other one's more central. So you can see those differences, and you can actually measure those differences with the ophthalmoscope if you look at those. So that's how accurate these are. In fact, this model has been modeled after patients we've seen. One of the eyes of these patients mimics one of those patients that Brenda showed in her presentation about the chemo plaque. So one of these eyes is modeled after one of those patients. So what is the impact of a 3D model? I think we can train medical staff. So we're actually designing a red reflex test curriculum based on this. That's being tested after we finish the design. I think these models, now that these are accessible to engineers, these models can be used as a disease phantom to create and test technology. What we showed you today was two different technologies, the arc light and the direct ophthalmoscope. Now you can see the difference between those two and maybe design technologies that are specifically used for retinoblastomas. Engineers, if you thought retinoblastoma is rare in the medical world, the engineering world has never seen retinoblastoma at all. So imagine what a 3D model of retinoblastoma can do for the engineers. If we just popularize the 3D model for engineers, maybe they'll come up with much smarter solutions than just these simplistic 3D printed devices that I'm showing you. Maybe they'll come up with AI and other things that can be trained based on these models, which truly show disease and truly show it the way that pediatric ophthalmologists say that it mimics the disease. Of course, last but not least, there's parent education and awareness. All of you can take these models and show it to different people and make sure that there's awareness. Some of the parents who saw the model today actually mentioned that they could see the difference between these eyes, and even the whole process of talking people through these models allowed parents themselves to learn what we see as doctors through our red reflex lenses. So I think it's a very powerful thing when you truly mimic a disease as a phantom. I think it's a very powerful thing. So what does the future look like for these models? I think we want to try and recruit medical students globally to validate the red reflex training curriculum. So as soon as the curriculum's ready, we'll be asking for help from all around the world to try and see if if we can train all medical schools all around the world with red reflex tests and how to do that. We want to engage our stakeholders and all of you in the room to help with fundraising and knowledge dissemination. So talk about these models and tell everybody about these models in a way that we can actually make more of these models. And I know that Sandra's already asked for some models, and I have no idea, how much they even cost to produce, because these are just prototypical models right now. But once we work that out, we'll obviously be giving Sandra the first models. And I've promised her that I'll give it to her in January-ish. I'm kind of hoping that I meet that promise. I have no idea how I'm going to get the money for it, so let's just wait and see, or how much money it even costs at this point. But truly what we want to do is to try and attract engineers as well to analyze retinoblastomas and develop solutions. What I'd like you to do is to scan that QR code, because what that QR code will let you do is have access to these 3D models that we've used to make one of these eyeballs. There are two different components to that model, one of which is the anterior segment, so the front half of the eye, and the other one is a retinoblastoma model that one of these eyes demonstrate. Now, the website is actually one step behind us. The website can't do color models. What you have on the website over there is only the regular shape of the model, but you can't actually have color details in the model. And now that you can't have color details in the model, we can help you with that. So what we'd like you to do is reach out to us, and we'll tell you how to get access to these models, make these models, play with these models. But I think it's important to do this because if you don't do this, the world doesn't know what retinoblastoma looks like. The doctors don't know, some of the doctors don't know what retinoblastoma looks like, and the engineers certainly don't know what retinoblastoma looks like. So these 3D models will hopefully change that and make a difference to the future. So thank you very much.
Thank you so much. That was fascinating. We are running a little late, but I think we can probably take maybe a couple of questions if there are any from the audience or anything on the chat online.
Right here.
Oh, sorry. Sorry.
My name is Joshua Castanon. My daughter, Elena Castanon, she was diagnosed at 9 months old, treated at CHLA. Dr. Barry, Dr. Shaw, now also sees Sarah Haddad. But I, obviously finding out more about retinoblastoma over the years, my daughter had her eye enucleated about almost a year and a half ago. The cancer, it came back, and we didn't want to put it through chemo again, so we decided we'd rather do enucleation. But before her eye was enucleated, we would go to, doctor's appointments or whatever, and I would welcome, whether they were MAs, LVNs, RNs, whoever, to take a look at her eye, because I wanted her, we had never heard of this prior to being, diagnosed, but I wanted to try to spread the word as much as I could. So I always felt, as a father of, retinoblastoma, I wanted people to see this, and finding out that medical professionals hadn't even seen this before, it amazed me. But I just wanted to say, you guys, everyone here, awesome job and everything you guys are trying to do to promote the awareness of this. But I took it upon myself too to try to let as many people as I could, especially in the medical professions. So not to say I used my daughter as an example, but I kind of did, because I wanted, what if they were to see another child and they could kind of identify it, or give a referral, which is what happened with us. I noticed my daughter's eye at 7 months old, lazy. Mm-hmm. We didn't notice the glow until after we had our appointment, which was 2 months later with the ophthalmologist. Thankfully, she was able to see it. But I just, after finding everything out, I just kind of made it a point. I wanted to let as many people as I could know about it. And with your guys' research and whatnot, thank you guys.
Thank you. Did you want to comment on that? Question?
Oh, you want to answer?
Oh.
Sorry, are you turning this thing on?
I think
There we go.
Yeah.
So thank you very much for that comment, and it's actually stories like that that have inspired these models. And in a way, I think we didn't have any better way to show it than to actually make it. And most of the children, they with a white reflex, once, let's just say, the eye has been saved, the white reflex looks vastly different from at diagnosis. And that will be shown to you even by the people who made the Cradle app. The child that the Cradle app is based on, or the concept was based on, actually showed how the tumor evolved in that eye and how the white reflexes changed over time. So I think it's important to freeze a point in time when you think this tumor looks a certain way, and therefore be able to show, small tumors, big tumors, different kinds of tumors in every way. I thought the only way to do that was using models like these, and I hope that works.
Melissa.
Thanks so much. I'm really excited about the 3D models, considering so many of us weren't diagnosed by our pediatricians, and this could be a really excellent way for them to have an idea of what they're actually looking for. And so I'm excited about this, and I just wanted to mention that maybe you were mentioning engineers that might even be able to make it better. I know that at Stanford and other places in the US, they have product design majors. And so one way to get maybe a less expensive way of making models and newer models would be to reaching out to product design programs and like make it a project for university students, things like that. I know someone who teaches that, so I'm gonna send him what you had on the QR code and see if I can do anything. This is how things happen, right? Is that we use our resources and our connections, and so I'm super excited that maybe they'll come up with something and that can help out. So later, but just an idea. Thank you.
Well, I just wanted to comment on that to say, please let them know that you first heard it in One Retinoblastoma World in Hawaii.
Absolutely. One more question.
Thank you. I just wanted to say something to balance out some of the comments I've heard during the time that's here, and to provide a little reassurance that the system is trying to train enough people and train them adequately. I realize that access to primary care providers isn't always straightforward or simple, and that there's a lot of material they need to master in order to practice. But there is something that started in Canada, and it started because the physicians involved found themselves practicing where there was a lot of material to master. And this wasn't today or yesterday, this was probably 35 years ago. And it was simply a tool for them to practice. It's called the Rourke Well-Baby Record. It is a long-standing standard. It became a standard for training family physicians, and it has been disseminated in multiple places around the world. And within the Rourke Well-Baby Record, there is a time slot somewhere between 3 and 6 months, and it may even come up twice, where pupil reflex, white reflex, is actually part of what's listed. Now, whether or not people are getting through everything on the Rourke Well-Baby Record, I don't know, but it is out there as kind of part of the training. And maybe people can pass that along, that it's actually some of the primary care, whether that's provided by a nurse practitioner, a family doctor, or a village health provider. That kind of system allows for saying, yes, it's necessary to do these things at time points. Thanks.
Thank you.
I just had one last comment on your talk, Maura. Thank you very much. I think, yes, these chatbots are now the new Google or whatever that is, or whatever that could mean. But what we used to think of as, parents Googling stuff and coming in to ask you questions is now going to be parents looking up stuff in ChatGPT and coming back and asking you these things. I had a comment about the readability that you've noticed over there. And my question to you perhaps is how, obviously you were paying for ChatGPT when you used ChatGPT Model 4, and maybe you were paying for the Gemini as well in some way. So these are personalized, personal accounts that you might have been using to actually access this information. I was recently introduced to a ChatGPT prompt, which basically I'd ask you all to ask yourself, because when I was told to ask ChatGPT, what do you know about me? And I asked ChatGPT that, and I was a little nervous when I read that because it knows a lot about you. And it designs the answers based on who you are. So when you tell me that the readability was a college level grad, I'm assuming that it was your account because you're a college level grad or more. So I have a feeling that it'll give different answers for different accounts, and maybe that needs to be factored in.
Yeah, you bring up an excellent point. So there is the new function, and now it discloses when you use it. That memory function is on, so it's recording information about the things that you ask. When we conducted the study, it did not have that function. I don't think that means that it wasn't doing it. It was probably still doing it, but not disclosing it. It wasn't necessarily my personal account, but it was one of my students' accounts. So to your point, they're also college graduate level. We did use a few things. I didn't go necessarily into the details of the methodology too much, but we used like little things that could try to decrease to account for the stochasticity of how questions or answers are generated. We asked it 5 different times, every time logging out and logging back in, so it wouldn't have memory from that same conversation that we were having, so it was a new page every time. And then we chose the most representative answer, and that was done through a similarity index score through CopyLeaks, which is also freely available. To your point, those are all like adjustments that we made to get the best, less biased possible result that we had. But does that guarantee that it wasn't biased? I don't know. I don't think we know, and it's entirely possible that all the information that gets retained when you input this chatbots played a role for sure. So, very good point. All right, I think this concludes our session. I'm going to pass it on to Sandra for the closing remarks. Thank you all so much.
Thanks very much, Maura.